I'm Christine Nawire. I'm a regional nutritionist at Arua Regional Referral Hospital. I oversee 8 districts from Maracha to Pakwach. That's supervising and monitoring the nutrition activities on behalf of the Ministry of Health and Government and on behalf of the Regional Referral Hospital. UNICEF, Arua Regional Referral Hospital receives children from various places because it's a referral center, and it also offers nutrition services where we have the nutrition ward, which provides inpatient therapeutic care for those patients who have severe acute malnutrition with medical complications. Also, we have outpatient therapeutic care for those patients who are severely acute malnourished without medical complications. In outpatient therapeutic care, we are giving F75 and the F100, or the F100 we use it for specially diluted therapeutic milk, which we give to children below 6 months. Then above 6 months, we are using the therapeutic feed, which is F75, and this comes in as, all the therapeutic feeds come in as a donation from UNICEF. UNICEF is also supporting us in system strengthening, where we are training other health workers from other lower facilities in other districts, and also it is also providing us with some support on mentorship of those health workers to see that these severely acute malnourished children are being treated well. It has also helped to implement the Ministry of Health community strategy, which is the MICAN. MICAN stands for Maternal, Infant, Young Child and Adolescent Nutrition, where we are using the care groups to reach, the care group volunteers to reach households, teach them about nutrition, assess their nutrition status of the children, their adolescents, the pregnant and the lactating women, and refer them to the facility. They also teach the community about hygiene and wash practices, and also help in the referral. With the community strategy, which we got support from UNICEF, the MICAN has helped a lot in identifying the malnutrition cases that were deep down there in the villages. So far we have formed around 68 care groups that were supported by UNICEF through Avis Foundation, and they are doing so well with our linkage and our early identification, as it can be reflected with the high numbers now we have right now. And then we also have the support from UNICEF, where we are doing the family-led work. We want the caregivers themselves to assess their own children and refer them. We have taught the caregivers, the mothers, the caretakers on how to assess their children for their nutrition status. In Arua Regional Referral, annually we see about 300 children under 5 years who are severely malnourished with medical complications in the ITC, and about 320 are admitted in outpatient therapeutic care. That means those who are severely acute malnourished but without medical complications.
The impact, how does it affect the child's
malnutrition growth? Affects the child in the child's health, because the malnourished child, first of all, will have a stunted brain, and when the child is stunted, that means even the brain is stunted, and that means even this child cannot perform well at school. It also affects the education, the performance in schools. Then malnutrition also can affect economically the parents. They spend on this malnourished child, and when they spend economically, even the government spends resources on a malnourished child, meaning even the economy becomes compromised. Then the health of the child is also at risk. Malnourished children, most cases, develop TB. Because of the weak immunity, the TB becomes active. And it affects the children in so many ways that even the child's health status become compromised.
Does it contribute to memory lapses?
Yes. It contributes to a lot. As we have seen early in OTC, we have seen a child that I told you was going blind. They had diagnosed that this child would not see anymore. But with the help of the vitamin A, was able to become okay. It even causes ascites, the swelling of the abdomen. It makes the body to swell. They have edema. Even the skin can peel. The whole skin peels off, and the child is in a severe state.
Is there a way of restoring a child who is malnourished to become normal and be able
A child who is malnourished can be restored. The way of reducing malnutrition is as early as the child conceives, because the malnutrition starts as early as conception. If the lady is malnourished, conceives a baby and does not feed well, that means that even that child will be born with low birth weight, and if he is not catered for well, this child will go into severe acute malnutrition. And if the severe acute malnutrition is not corrected within the first 2 years of life, the child's body remains stunted. Inside, the organs do not develop well, and this child will still pass on to the other. When she grows and maybe gets pregnancy, if it's a girl, passes the malnutrition to the unborn child.
What would have Arua Hospital done without the support from UNICEF and the Swedish government?
Without the support from UNICEF, Arua Regional Referral Hospital would have no therapeutic feeds, because all the therapeutic feeds we are receiving in Uganda is from support from UNICEF, and this is what we use for treating severe acute malnutrition. That means as a country we would be losing a lot of children who are below 5 years and due to malnutrition. And also, without the support from UNICEF, we would not have system strengthening. We would not go to other facilities, other districts, supporting them, training them, mentoring them on how to treat and assess these malnourished children. And even the community strategy, the community MICAN, the volunteers would not be trained, because all the support, the strategy was implemented with the Ministry of Health, but because of lack of funds, we were not able to implement it until UNICEF came into the picture. That's when we were able to be supported to implement, to start, to initiate the MICAN strategy, which has worked very well, because the volunteers are reaching the fellow households, the neighboring households, and they are helping in assessing and referral of those malnourished children.
Tell us about the survival rate of malnourished child who is not saved in time.
The survival rate of a malnourished child who is not saved in time is minimal because of reductive adaptation. The malnutrition makes the body system to go into a shutdown. It reduces the functioning of the organs, and if we not intervene in time, we end up increasing the death rates of those children.
Doctor man mayo gamba ma basunju kasen mani ma ko yoga zata ba jemani apa grunsha se apa ki ma nyaka sin basuna mbe aya che don ramo drido ki ma jinwa nga bam dinde supe er ma ko ba mo sin bene na sana uzu aya ba ji do belen ramade
sa seriate bande basu midra
basu do warate
bande tesa sora
odo ta do
erse bandu maka
oro do bandu raba kilindiri ne ko e kale ba ferni ndrata ne ba ku ba mi baza afa ko pazi vuder mala mezale ne aya mi do ferni re do vura
nya sa de usi
mai ma do cha andro si ta do afa embalo ne fidando suliri
ngande mambate si
Ermamba alumi fia ndra sabati si
mirta ne
asiba granda
nimbo kore milite si
Bali mtu na
batamba aya ni mbarele ko nyaka tabanya di bafenvani di hasgal nya sia dira nya I asazi sia di ko te residio ya dira de siso de ko ya vani de si abirisi kade ro abirisi lewo el maro pani ki di invisi pere ni dia sazo extend zi di roti ki di tutu
okay ngami ngokore
iyo
azida bikya silera
azida ki di leko askoni mo dienda ai magaye personal mai mabi matamba mai tamusu divi ne zide sima bie moto aziti bale ne manu ba ko katele alobo ne va ko ku aya de ko diva de ku house galbe erge house galbe di kanembani yo woro de bur di house galbe mai binisi aka zinsi rumo timbar nyanya kara ya munu yara te mani di mani ne nyaka store ni jese mateka nyaka dalen ba nyara de nyanya nyaka ko so mam di belo do sai nyaka ko ruti roki dutu like pane di roku tu aya erma tu erma andriti derke oro nyaka brown ruti aya mam di ibade di ngani ati kama di ya rozo arma ko kama za ibade ya dilen yarsi di belo ne rubi mani di rozo ya ban ma kisu de so ti
okay so dimbata misuna vutia eyo mindika mimujara ngona skuni 11 zirele tani vano trami million pili kami ngona okay miti azida ngona
masika skula
adoro
masika kilinaro skula
okay so dimavutia minika sitia mo azita bantalo minjara vutia opina zikinbar manyanya kamu kerngona
Bari dri matiri mo sar sedeni house galon ko par matamba kula drara mati tira zini mani tira dia yani ermambati ndimva matabambangone areta motoni vini mi record le sivade imontazo le siko manga mozima buringa bitisi so susa to ida meme kiswele madre ko sa nyaka furka tsa de le bitisi man murezima var nyaka feraka kama dusi mamundo aka febo aka ikanyabo mairoto kilindi madi mozie matiri kuzangara vondo aka rekuwa mazinga bayram saturday sudra sense mavura debo aka debo mavini gokuole last time musuma kuma ferni nyaka mai maneri nyaka nyangoni erma pataikitia yoari kilindi rakaka mama kuvini rezamara bendo
ikuntamirole
marudra Christine
mbade maali disi
mbade mele alo ngamduni alo
beji mdiangora
Bejima wiki enteru virisi.
Ni alita de
Wiki alo ya dandusi.
Yo ban di shuro ni aralo.
Yo ban su ban lo maneri keneri mari mo pota ko nyaka ruoni akliliyo.
It's coming because of the general support from the Embassy of Sweden. And just to start a little bit, as UNICEF, we work really to advocate and protect the most vulnerable and disadvantaged children by supporting the government to address the issues of inequities in health outcomes, working directly with the district local governments that have got the law coverage to tackle all issues of inequity by supporting the district's health system strengthening. So with the support of Embassy of Sweden, this is what we've been able to do starting in 2017, I think that was September 2017, with funding from Sweden, a comprehensive package of interventions for the women and children in West Nile region. I've been supported. Just to let you know that this is taking into consideration all the programs under health, and when we're looking at the health component, the general health, as UNICEF we use the life cycle approach. Right from the neonatal health, a comprehensive package of support to ensure that the health of children, the newborn care and support, the component of child health, adolescent health, maternal health, not forgetting the issues of HIV and AIDS, the struggle to eliminate the spread of HIV and AIDS in the region. We have seen from the recent statistics that the data is increasing, the infection, it's becoming more and worse of all. The most affected are the adolescents that we all seek to support. So with CEDA support, a number of interventions have been supported, including strengthening the capacity of the district leaders in the management, evidence-based prioritization, and program monitoring and evaluation. The detail, you will be able to interact with the stakeholders in the different sites that you will be able to visit. But also I hope that through this mission, you will have an opportunity to interact with the beneficiaries in those households, in the communities, and they will be able to give testimony of how this support has impacted on their lives through the different interventions supported. Improving availability of and access to quality services for women and children by training and providing the mentorship to health workers is one of the components that was supported by SIDA. We have had some health workers that were deployed in some of the districts, and we are happy to note that with the good gesture by the ministry, by the Embassy of Sweden, some of the health workers that were deployed in the government health facilities, we are happy to note that some of them have been taken up by the government and they have been integrated in the government system and facilitated by the government. In addition to that, also increasing demand and participation of communities is a key component that was supported. You also know when we are talking about health, especially the primary health care, the importance of the community engagement is very key, and we have been able to support this through the rolling of the key family care practices, working with the different community structures, the government structures at different level, not forgetting at the village level, the VHTs have been core in ensuring that all this support is a success. And just to conclude that supporting the demand for health and nutrition services, nutrition was one of the key components that has been supported with the funding from the Embassy of Sweden. And not forgetting the beautiful wash facilities that you will see in those health centers when you visit. You will be able to see the wash facility, the water supply, but the component of sanitation and hygiene in the different health facilities that you'll have the opportunity to visit in Koboko, in Arua, and in Ajumani. So not to take a lot of time, but it is a pleasure to having you here. We hope that through this mission, you'll be able to interact with the different stakeholders, the government stakeholders, the community leaders, and most importantly, the beneficiaries, so that they can give the testimony of how the interventions that UNICEF has supported through the general support from the Embassy of Sweden, how it is directly transforming their lives and contributing to improving their well-being.
We also receive support in terms of equipment, in terms of training, in terms of commodities for nutrition. Some is not somewhere, it is severe acute what? Malnutrition. Yes, so outpatient care services, we see that over time the numbers went up, but now we're coming down. The nutritionist will tell you that we are embarking on prevention also in terms of nutrition care. There's the community maternal, infant and young child and adolescent nutrition initiative through care groups, and we already are feeling this. Actually, if we had the figures for 24-25, you will see indeed the admission rates for severe acute malnutrition are coming down. We have maintained a good picture in terms of the care. OTC is outpatient therapeutic care. We have ensured that no one dies in the OTC and they fully recover. However, we have death in the inpatient therapeutic care, sometimes because, or mainly because the children are brought in very late. If you see some of those children, they need to be in an ICU. They need to be in an ICU to provide their care in terms of the medical care as well as the nutrition care. But overall, we see trends of reducing reducing death rates. These figures, 11.2, may be one child who has died out of 20. So it depends on how many you have admitted that month. Not so. So that's an area we are trying to work on. Prevention through the MyCan initiative, and if that does not work out, and then timely offer treatment. So here we talk about the commodities that are available for use, and over this time we have not had issues of stock out, except was it this year? Last year transitioning to this year because of a transition issue and other challenges which eventually got addressed. I think it was beyond UNICEF or even Ministry of Health. But eventually we had the commodities come back and we were able to take care of our babies. Now, it's true that the babies, when they are born small, they are not yet fully mature to exist in the outside environment. That is why the interventions that are done should be critical in ensuring that these babies, one, survive, because that's the first thing, and they thrive. And this actually starts before the delivery. For the small babies, especially those before 35 weeks of gestation, usually we give some medicines. We give corticosteroids. Those less than 32 weeks, we give magnesium sulfate, and which all ensure protection of the lung, protection of the brain, and then warmth and so on. So when these babies are with us, the care package is to ensure that we support their respiratory system, give them oxygen by different mechanisms depending on what they can tolerate. We give them fluids, and we also start nutrition care, breastfeeding. Now, breast milk is very critical for these babies' brain development, and ultimately that is the worry for most of these babies. If therefore their care is optimally done and they are started on breastfeeding as per the provided protocol and timely, we find that there's pretty much no difference in terms of their long-term outcome. Our follow-up clinic provides for follow-up. Initially, we were doing a follow-up of up to 1 year, but with the latest orientation we received on developmental care and follow-up of these babies, we are extending our follow-up to varying between 2 and 5 years, depending on what outlook we see in the baby. Those who are most small, the small, or those who had asphyxia, we're taking it up to 5 years. And we have modified our follow-up register to capture aspects of developmental care. But from literature, those who have been well taken care of, offered the optimum care, they fare very well. You actually see no difference between one who was preterm at birth and one who was term at maybe 2 years, 5 years, or in class performance. So the future is still the same for them. Yes, the referral system, we follow a structured referral system that looks at referrals from the lower facilities to the higher facilities. It is structured such that it should move from 3 to 4 hospital, or where there is no level 3, or where the hospital is nearer to you. If we pick a place like One Health Center, One Health Center is nearer to Arua Hospital, so they would refer to us. So that's our referral structure, and there's a system in place. There's an emergency medical services coordination, where there are focal persons to whom who can be reached to initiate the referral or access the ambulances, and that is working fairly well in the region. It's one thing the region is credited for, so it's working well. Also thanks to partner support and government initiatives as well. In terms of our capacity to care, I did mention that where we are is a bit small. The current paradigm is that we're supposed to have the mother and baby together at every stage, and that is the future we look at. So I use this opportunity to also appeal that later on, when you look at the facility, the unit, it's definitely small. What we have done is to offer as optimum care as possible to reduce time of stay in the ward. When you reduce time of stay, you have more beds available. Right now, we have had additional beds provided, and we don't have babies who are crowded, 2 babies per bed. No, we don't have that in our unit. It increases risk of infection. But the long term is a bigger facility. And I'll mention, okay, in terms of aggregation, I don't have the figures offhand. We moved from 7% of the services overall being received by persons of concern or refugees, and this figure came down to, I don't know, 4% in the last evaluation. So, but we can't pick up in specific terms. Maybe Dr. Dad has that, because when they come to us, for us, we see them as patients. It's maybe in the registers that we have that disaggregation. But yes, we get persons from, because Rhino Camp is next to us, Terego is next to us here. And in the past we used to get from Yumbe, but the referrals from Yumbe are now coming down. Most of them are going to sustainability. I don't think these initiatives are in vain. The beauty is that they were, if you look at the scope of support that we have talked about, its equipment, its skills in already existing government stuff. Unless I retire or get transferred and other things, I am going to be here. So in terms of the care package, the skill continues to stay. And the relationship that has been created, we think we don't take it for granted. And I don't think UNICEF is also going away. Please don't go away yet. Please don't go away yet. And we continue to learn. As you address and solve one issue, maybe other challenges may arise. When those do come, we will manage them as appropriate. The immediate complications, they suffer issues around respiratory complications because their lungs are not yet mature. Ability to maintain body warmth because they don't have fat under the skin, and their intestines are small, the mouth is small, everything is small, they may have feeding difficulties. So if those are not addressed well, the baby might not survive, and that's why I did talk about respiratory care, and then warmth, supporting feeding, and ensuring infection prevention and control. Because if you don't address this, any of these can cause the baby to lose their life, and our effort is geared towards achieving this in all the preterm babies. In the long term, if you don't start the nutrition care optimally, you can have a situation of stunting. The baby may not achieve the height that they should achieve when they become term. So long term, they may have stunting, they may even fail to thrive, and other complications. Some of them may have developmental challenges, issues around attaining your milestones, being able to crawl, walk, being able to talk, your mental acuity, and other developmental disorders like autism spectrum disorders. And that's why we have reviewed our follow-up schedule to extend to up to five years, within which to be able to pick some of these and support them appropriately. But importantly, try as much as possible to minimize the occurrence.